Hello and welcome to my channel. This is Pritesh Jadhav and today we shall be understanding a very frequent clinical symptom and ward finding known as ascites. So without wasting further time, let's get started. Firstly, with the definition. Ascites is defined as an accumulation of fluid within the peritoneal cavity. Small amounts may be asymptomatic. The increasing amounts can cause abdominal distension and discomfort to the patient. Anorexia, nausea, early satiety, heartburn, flank pain and respiratory distress can often accompany a patient of ascites. Now we shall see the detection. Physical examinations include a bulging flank, fluid well, shifting dullness, a puddle sign which is a dullness on the dependent abdomen when the patient is put on his hands and knees. Maybe it is associated with a penile or scrotal edema, umbilical or inguinal herniation, pleural effusion as well. Evaluation should include a rectal and pelvic examination. Assessment of the liver and spleen is done. Pulmonary erythema and spider angiomata is seen in a case of cirrhosis. Periumbilical nodes, that is the System-Airy-Joseph node, suggest a metastatic disease from a pelvic or GI tumor. Ultrasonography and CT scan is very sensitive and can distinguish the fluid from cystic masses. Evaluation is done by a paracentesis. About 50 to 100 ml blood ascites fluid is required. Routine examinations include a gross inspection, protein, albumin, glucose, cell count with differential, grams and acid fast stains, culture, cytology. In selected cases, amylase, LDH, triglycerides, culture for tuberculosis is done. Rarely laparoscopy or even exploratory laparoscopy may be required. Ascites due to a CHF, example in pericardial constrictions, may require an evaluation of the right-sided heart catheterization. Differential diagnosis. More than 90% of the cases due to cirrhosis, neoplasm, CHF, tuberculosis, diseases of the peritoneum, including the infections, that is bacterial, tuberculosis, fungal, parasitic, neoplasms, connective tissue diseases, miscellaneous like the Whipple's disease, familial Mediterranean fever, endometriosis, starch peritonitis, etc. Diseases that do not involve the peritoneum like the cirrhosis, CHF, Budd-Chiari syndrome, hypoalbuminemia and miscellaneous conditions like mixed edema, ovarian diseases, pancreatic diseases, chylous ascites. Pathophysiology. Classification including the serum ascites gradient, albumin gradient, SAG, which counts the serum and the ascites and reflection of the imbalance of the hydrostatic pressure and can be used to differentiate between the potential causes of ascites. Cirrhotic ascites. Pathophysiogenesis contributing factors include a portal hypertension, hypoalbuminemia, hepatic lymphatic vessels, renal sodium retention secondary to hyperaldosteronism, increased sympathetic nervous system activity from the renin-angiotensin production. Initiating events may be peripheral arterial vasodilation, which is triggered by the endotoxins and cytokines which are mediated by the nitric oxide. The treatment includes maximum mobilization of fluids, that is 700 ml per day, and rigid salt restrictions to less than 2 grams of sodium per day. For moderate ascites, diuretics are usually necessary, like spironolactons in doses of 100 to 200 milligrams per day per oral, and furosemide 40 to 80 milligrams per day per oral, or IV may be added if necessary. There is a greater risk in the hepatorenal syndrome and encephalopathies in such patients and can increase to a maximum of 120 to 160 milligrams per day until the effect is achieved or a complication occurs. Thirdly, monitor the weight, urinary retention of the sodium and potassium, serum electrolytes and creatinine is useful. If the ascites is still present with the above measures, then it is defined as a refractory ascites. Treatment modalities for such a condition include a repeated large volume paracentesis of more than 5 liters with IV infusions of albumin, 10 grams per liter of ascites fluid removed. Consider transjugular intrahepatic portosystemic shunt, TIPS. While TIPS manages the ascites, it has not been found to improve the survival and is often associated with the hepatic encephalopathy. Prognosis for patients with ascites and cirrhotics is poor, with less than 50% of survival 2 years after the onset of ascites. Consider liver transplantation in appropriate candidates with an onset of ascites. Now we shall look a brief about the complications of ascites. Spontaneous bacterial peritonitis in suspected patients of cirrhosis and patients with ascites, a fever, abdominal pain, worsening of ascites, ileus, hypotension, worsening of the jaundice or encephalopathy may supervene, and in lowering the ascitic protein concentration, that is a low opsonic activity, is a predisposing factor. Diagnosis consists of is suggested by ascitic fluid cell count of more than 250 per microliter, and it is confirmed by a positive culture. E. coli is more frequently found in such patients. However, gram-positive bacteria like Streptococcus viridans, Staphylococcus aureus, and Enterococcus can also be found. Initial treatment includes cefotaxime 2 grams IV 8 hours a day. Risk is increased in patients with varicose bleeding and prophylaxis against spontaneous bacterial peritonitis. It is recommended when a patient presents with the upper GI bleeding. Hepatorenal syndrome is suspected. Functional renal failure without a renal pathology occurs in about 10% of the patients with advanced cirrhosis or acute liver failure. Thought to be a result of an altered renal hemodynamics, two types of HRS are seen. Type 1, in which there is a decrease in the renal function within 1 to 2 weeks of presentation, and type 2 HRS, which is associated with a rise in the serum creatinine, but it is associated with a better outcome, often seen in patients with refractory ascites. Treatment includes midodrine along with octreotide and IV albumin for either type 1 and type 2 HRS. Prognosis is poor in the absence of liver transplantation. If you found this video to be helpful, please consider liking and subscribing to my channel to bring more such videos to you for betterment in your knowledge of medicine. Thank you very much.